Good evening, sir. Good evening, sir.
Hi, Samastri. Good evening.
Hi, sir.
Thank you. Thank you for joining. Hello, Dr.
How are you?
Vaikundaraju. Is it Dr. Vaikundaraju? I think he is getting done. So, how are you, Samastri?
Sir, yeah, fine. How are you?
I am good in the midst of the heat.
I wonder how can you manage time now? Very, particular regarding this academics
Uh,
every week.
no. It is just, this happens somehow. Busy day for you today?
No. Actually, Puja vacation, Puja roster is still going on now.
Oh,
So
okay,
that's
okay.
fine.
Still
Yeah.
on holiday.
So after round, we are free. So it's
Okay,
not like any other day. So after round, we just leave and senior resident manage. So that's it.
okay. Great.
We have to attend the calls. That's it.
Okay.
So we have Dr. Vaikunta. I think he
Yeah,
is here.
Vaikundaraju, I think he has joined. Hello, sir. Dr. Vaikundaraju.
Yes, sir. Good evening, sir.
Hello, sir. Good
evening.
evening. Thank you. Thank you so much for joining, sparing your time.
Thank you. Thanks for invitation.
This is Dr. Somasri. She is a consultant neonatologist from Kolkata.
Yes,
Hello,
sir.
sir.
Hello, madam. Hello. Good evening.
Yeah, good evening.
Dr. Dasaratha, have you? Where is? Okay, no, it is not. I think he has not yet joined. He was having some problem. Mateen, can you please call him because he said he was trying to log in, he could not join.
No, sir. He just logged in delegate. I'm just promoting to panelist.
Oh, all right. Okay, fine.
Done, sir.
So we'll wait for 2 minutes, and then once he also joins, then I think we will start. And people, yeah, once we have a reasonable attendance, I think already
Good evening, sir.
have 64 participants. Hello, hi, Dasratha.
Hi, sir. Good evening, sir.
Hi. Good evening.
Sir, good evening, sir. Vaikuntra, sir.
Yes, sir. Good evening.
Good evening, madam.
Dasarath, this is the second day consecutively we are meeting.
It's a great opportunity for me, sir.
Hello, good evening.
Hello, yeah. Dr. Somashri, you know Dr. Somashri? She is a consultant neonatologist, professor from Calcutta Medical College.
Yes, sir.
Hello.
Okay. Hi, madam. I know Vaikuntra, sir. He is more associated with our organization. He used to come as a visiting a neurophysician for our Kalyan Durg branch of RDT Hospital.
Chandrakala used to praise you so much, Vaikuntraju sir. So that's how I heard of you. Otherwise,
Okay.
we don't know.
Thank you, sir. Thank you.
Your passion for pediatric neurology is well known.
Thank you. Thanks.
I think we have some 74, 75 people who are joined. I think we'll start because of
Okay.
we get the session. Will get. So, hello everyone. Now, one second, Dasratha. Yeah, you can check the slides and then stop sharing. Hello everyone. Good evening. Welcome to the next session of Noel. Now, some of you NNF fellows who are appearing for the exam next week, this is going to be a sure question, so probably you need to pay attention. For others also, those who are doing the neonatal training and those of us who do take care of babies, one of the organs that we mostly tend to ignore is the brain. The organ that controls everything else we don't monitor. We monitor everything else. We monitor the gut. We monitor the kidney. We monitor the saturations. We monitor everything else. But brain somehow, because of the complicity and with the other problems involved, we most of the time tend to ignore. Until now we have something very simplified machine that you and me can use. We don't need experts like Dr. Vaikundaraju to actually, interpret the findings of a neonatal EEG. We have something called aEEG. The CFM is something that you and me can monitor, interpret very, very easily. So that is what we are going to learn today. In the last 2-3 sessions, we have been talking about hypoxic ischemic encephalopathy, and we have covered what should be the supportive management of a neonate with asphyxia. We also looked at the cooling, the therapeutic hypothermia, and the evidence behind it. So, if you remember what was stressed in the last class regarding the criteria for enrollment of therapeutic hypothermia, you need to meet the criteria for hypoxia. That is the criteria A, which you meet, and then of course in the change scenario with the NNF guidelines in place, probably you need to make little bit modifications, and then once you have fulfilled your criteria A, then you go for criteria B, that is the presence of encephalopathy. So hypoxia is there. Now encephalopathy. Criteria B, you go exclusively by scoring, Thompson scoring or modified Sarnath scoring systems, and then you establish that, okay, this baby requires therapeutic hypothermia. But also there is a criteria C, which is aEEG. It is not mandatory to have it to initiate cooling, and the use of aEEG goes beyond just monitoring a baby on therapeutic hypothermia. It has various other uses as well. So we are going to learn what is important for your exam from the exam perspective from Dr. Dasaratha Ramaiah. And he is known to all of you. He is one of the young budding neonatologists who also has the distinction of being a pediatric neurologist as well, having done the pediatric neurology course as well. So he is the right person to tell us about how to read an aEEG. To moderate today's session, we have Professor Dr. Somashri from Kolkata Medical College. She is again another young neonatologist known to all of us, very active in academic circles. The expert for today's session would be an authority on this. Most of you would have heard his name in some context or the other, Dr. Vaikundaraju from IGICH, Bangalore. So, with this array of three experts, in fact, we have Dr. Dasaratha, Dr. Somashri, Dr. Vaikundaraju. We are going to learn a lot today, and I would request all of you to kindly post your questions in the Q&A box, and of course you may post in the chat box as well, but probably better to post in the Q&A box. At the end we would have the discussion. Kindly you should know at the end of this session, you should know if in OSCE slide is presented and interpret the aEEG finding, or maybe a short note on aEEG. It can come in theory, in practical, in various forms. CFM can come. So there is no getting away from that. These are newer things in neonatology which we need to know. Like we talked about POCUS. Now this is again another field. So CFM is there to stay. Probably if we get time before we wind up this year, we will talk about NIRS also. Probably we will not be discussing now. You can, for those who are preparing for exam next week, you can prepare a short note on NIRS. Next week, since we have our exam on from 14 to 16 for some of you, we will not be having the session on Friday. We may have a special session for you on Thursday on how to prepare for exam and things like that. It is not finalized. I will share the details with you in the subsequent days. So with this, we would start today's session. I would request Dr. Somashri, the moderator, to give an overview and then invite the speaker to start the session. At the end, we will have the discussion. Over to you, Somashri.
Sure, sir. Yes. Thank you, sir. So, may I invite Dr. Dasharatha to start the session? And of course, at the end, I will tell the question one by one, and our expert, Dr. Vaikanta and Dr. Dasharatha, both can answer. So accordingly, we can move.
Thank you, madam. Thank you, Manoj sir and NNF for giving me this opportunity. So today our topic is on amplitude integrated EEG, as rightly given the background by Dr. Manoj sir. So what exactly it is? The recording of difference of potentials between two electrodes. At least one electrode should be over the brain. So as you can see in this image, if we measure the difference between the potentials of two electrodes which are placed on the brain surface on the scalp, it is called bipolar. If only one electrode is on the surface and other is a reference electrode out of the brain area, then it is called unipolar. And coming to this amplitude integrated EEG, here we use very limited channels, and the difference between the potentials is displayed in a semi-logarithmic and time compressed scale. So in this image, you can see the conventional EEG electrode placements. But in amplitude integrated EEG, we use very limited channels, and which will be displayed in this semi-logarithmic and time compressed scale. And we'll see what exactly these words mean. So in amplitude integrated EEG, we normally place two electrodes on parietal regions. Left is indicated by P3 and right is indicated by P4. And this is the ground electrode. But sometimes if it is a two-channel amplitude integrated EEG, we can add even C3 and C4. Two fingers anterior to parietal leads, we can use these central leads C3 and C4. So always bihemispheric method is more superior, which will tell us even asymmetric changes in both hemispheres. So that is what it is called as limited channels, what we use in amplitude integrated EEG. Semi-logarithmic means from, so obviously this electrode difference, the potential differences will be denoted by microvolts. From 0 to 10 microvolts, the scale is linear, and from 10 to 100 microvolts, the scale is logarithmic. So with this method, the signal in the lower amplitude is enhanced, whereas a signal at higher amplitude is attenuated. That's why it is called as semi-logarithmic.
Recording in progress.
And what it is meant by time compressed. So amplitude integrated EEG displays the bandwidth of EEG, which reflects the trend of maximum and minimum amplitudes at a speed of 6 centimeters per hour. And this slide is very important to understand what exactly the amplitude integrated EEG is doing and displaying from the conventional EEG. So the display time is 6 centimeters, but it is compressing 1 hour record of conventional EEG. That's how amplitude integrated EEG is compressing the data from the brain activity. So if 6 centimeters of amplitude integrated EEG is showing 60 minutes of conventional EEG recording, so 1 centimeter is showing 10 minutes of activity. 1 mm of amplitude integrated EEG is showing 60 seconds of conventional EEG activity. So in this image, it is 20 seconds of conventional EEG record. So obviously this line, this vertical bar, which is there over the amplitude integrated EEG. So that is 1/3 of mm, so 0.3 mm. So that 0.3 mm of amplitude integrated EEG is reflecting the brain activity, which is through this 20 seconds of conventional EEG. So what is this trends of maximum and minimum amplitude? How exactly it is reflecting, denoting the conventional EEG into amplitude integrated EEG, we'll see. So in this 20 seconds of conventional EEG, there are two areas where you have a maximum amplitude and where you have a minimum amplitude. So this maximum amplitude is represented by the upper margin of the amplitude integrated EEG. And this minimum amplitude in the epoch will be represented by the lower margin of the amplitude integrated EEG. I think it should be clear, and we will see in other examples also. So let us take this example of a conventional EEG in a neonate. So it is clear that most of the record is continuous, more or less is a continuous with much less variability in the amplitude. So this continuous record normally present in whether either in the awake state or in the active sleep, and this is a discontinuous conventional EEG record. So this discontinuous discontinuous EEG record in newborns indicate it can be in the quiet sleep. So this is the amplitude integrated EEG. So obviously, whenever there is a discontinuous record, the maximum amplitude will be higher and the minimum amplitude will be very less. So as we have discussed, the maximum amplitude will be represented by the upper margin and the minimum amplitude will be represented by the lower margin. So this discontinuous record will be shown as a broad bandwidth in amplitude integrated EEG, as lower margin will be very low due to this very decreased amplitude in this discontinuous conventional EEG. Whereas in continuous EEG, even the minimum amplitude is higher. It's higher than 5 microvolts. So obviously the bandwidth will be narrower, as you can see in this amplitude integrated EEG record. So this narrow amplitude integrated EEG bandwidth indicates either it is in the awake state or active sleep, and this broad bandwidth indicates that it is a discontinuous record and it can be due to quiet sleep. And so there you can see in this picture there is a sinusoidal pattern transition between the broad bandwidth and narrow bandwidth, and broad bandwidth and narrow bandwidth. This sinusoidal pattern of transition from broad bandwidth to narrow bandwidth and again to broad bandwidth is called sleep-wake cycling, and we'll know about this even in the further slides. So these two slides are very important to understand what exactly this amplitude integrated EEG is doing by changing the data from conventional EEG and representing us into a very compressed manner as a bandwidth. So how this amplitude integrated EEG is assessed. So previously, Al Nakib et al. He has given a voltage criteria to classify amplitude integrated EEG either as normal or moderately abnormal or suppressed. Or normal means upper margin will be more than 10 microvolts and lower margin will be more than 5 microvolts. Moderately abnormal means upper margin will be more than 10 microvolts and lower margin will be less than 5 microvolts. That is, so here upper margin is more than 10 microvolts and lower margin is less than 5 microvolts means it is a broad bandwidth. If there is no sleep-wake cycling and it is a continuous broad bandwidth only, then obviously it is a abnormal. That is a discontinuous record throughout. Suppressed means upper margin being less than 10 microvolts and lower margin being less than 5 microvolts. So both upper and lower margins were less than 10 microvolts and less than 5 microvolts respectively in suppressed. But later, Hellstrom, Vestas et al., they came up with another classification including the pattern recognition along with the voltage criteria. So here in the pattern recognition, they have given more importance to sleep-wake cycling. So continuous background pattern with prominent sleep-wake cycling. So as we have discussed in the previous slide, so upper margin will be more than 10 microvolts and lower margin will be more than 5 microvolts, but with a sinusoidal transition from broad and narrow bandwidths, which is indicating active and quiet sleep. Whereas in discontinuous background, upper margin will be more than 10 microvolts only, but lower margin will be less than 5 microvolts without any sleep-wake cycling. Burst suppression pattern. Here, the upper and lower margin will be less than 10 and less than 5 microvolts respectively, but they will be associated with number of bursts, that is number of spikes. and they are classified again into burst suppression plus and burst suppression minus. Burst suppression plus means if bursts were more than 100 per hour, then it is called burst suppression plus. Burst suppression minus means if burst activity is less than 100 per hour. And we will see in other example what exactly this burst suppression plus and burst suppression minus means. And another classification is continuous low voltage. Here upper margin is less than 10 microvolts and lower margin is less than 5 microvolts. So it is as it is in the burst suppression pattern, but here the number of bursts or spikes were very occasional. There won't be n number of burst activity or spike activity in continuous low voltage. Whereas in isoelectric or flat tracing, both upper and lower margin will be less than 5 microvolts. So sometimes in even flat tracing, you can observe some spikes, but they are mostly due to artifacts. So coming to sleep-wake cycling, it is a smooth sinusoidal variations, and those variations obviously will be in the minimum amplitude. So as we have already discussed how exactly this amplitude integrated EEG is denoting the conventional EEG. So whenever there is a less difference in the lower in the minimum amplitudes, obviously this lower margin will be either above 5 microvolts or below 5 microvolts. The broader bandwidth represents the discontinuous record, and narrow bandwidth indicates either it is in the wakeful state or active sleep, and there should be a sinusoidal smooth transition between the two bandwidths. Then it is called as a good sleep-wake cycling. If there is no cycling, then it indicates some cerebral dysfunction is there in the baby. So we'll see examples of the amplitude integrated EEG. So this is from left hemisphere, this is from the right hemisphere. So in here you can see clearly the broad bandwidth, and this is the narrow bandwidth, and again the broad bandwidth, and again the narrow bandwidth. So obviously there is a clear-cut sinusoidal transition between broad and narrow bandwidths, and upper margin is above 10 microvolts and lower margin is above 5 microvolts. And this is a clear-cut continuous normal voltage pattern with good sleep-wake cycling. So this is an example for discontinuous normal voltage pattern. So discontinuous voltage pattern normally we see in the preterm babies. Here upper margin is above 10 microvolts, but lower margin is below 10 microvolts. And here you can clearly see there is no sleep-wake cycling. Coming to continuous low voltage pattern. So here upper margin will be less than 10 microvolts and lower margin will also be less than 5 microvolts. But the number of spikes will be occasional only. And we'll see the difference, how it differentiates itself from burst suppression. So this is burst suppression pattern. Here also upper margin will be less than 10 microvolts and lower margin will be less than 5 microvolts, but there will be a continuous burst activity, continuous spike activity, and it can be divided into BS plus or BS minus depending on the number of spikes. If it is more than 100 per hour, it is BS plus. If it is less than 100 per hour, it is BS minus. Coming to isoelectric tracing or a flat trace. So here both upper and lower margins are less than 5 microvolts. And whatever spikes we see here are artifacts mostly due to patient movements. So now we will see how an epileptic seizure will be seen in amplitude integrated EEG. So there will be abrupt rise in the minimum amplitude, that is lower margin, and a simultaneous rise in the upper margin of the amplitude integrated EEG. And often it is followed by a short period of decreased amplitude. And always whenever we see the pattern, we should correlate with the conventional EEG recording. So whether that is showing gradual build up and then decline in the frequency and amplitude of repetitive spike and wave pattern is there or not, that we should confirm. Otherwise, there are many artifacts which can resemble an epileptic seizure activity in amplitude integrated EEG. So if number of seizures were more frequent than at 30-minute intervals, then we call them as repetitive seizures. If seizures were ongoing continuously for more than 30 minutes, we label them as status epilepticus on amplitude integrated EEG. So in this example, we can see these solitary epileptic seizures, and here almost continuously they are present. So it is a status epilepticus. Here the seizures abandoned with the injection midage, thereby returning to the baseline activity. And here it is also showing a abrupt rise in the lower margin of the amplitude integrated EEG, but the conventional EEG correlate is not showing any spike wave activity. So obviously it is an artifact. Whereas in other amplitude integrated EEG examples of epileptic seizures, you can see continuous spike wave pattern in conventional EEG, which is absent in this example D. So let us see one example of how amplitude integrated EEG will be helpful in monitoring a hypoxic ischemic baby. So baby is not having clinical seizures, but on amplitude integrated EEG, there's a continuous seizure activity. So this is conventional EEG, this is amplitude integrated EEG. So there is an abrupt rise in the upper and lower margins, and simultaneously in conventional EEG you can see repetitive spike wave pattern. So in this example, we can see how the electrical seizure activity stops with the midazolam injection by resuming the baseline activity. So here we have given midazolam, and then it became a baseline activity. So where exactly we use this amplitude integrated EEG? So obviously we all know in all cases of hypoxic ischemic encephalopathy who are kept on therapeutic hypothermia, they should be monitored for cerebral activity and ongoing seizures with amplitude integrated EEG, and it should be continued for throughout hypothermia period and at least 24 hours after hypothermia stopped. And whenever we see seizure mimics, whenever we have a doubt, so like apneic episodes, and there are autonomic signs like hypertension and tachycardia. So to confirm whether they are seizure related or not, then also amplitude integrated EEG will be useful. So other neurological disorders like congenital malformations or post cardiac arrest, inborn errors of metabolism like urocycle defects, which may result in a severe cerebral edema. So there also the brain function we can assess through amplitude integrated EEG. In term baby, the amplitude integrated EEG will tell some prognostic markers like bus suppression, having a continuous low voltage or isoelectric tracing is a very poor prognostic marker in term baby with a HIE or post cardiac arrest. And in full term babies, 73% of seizures which last for more than 30 seconds and 87% of seizures which last for greater than 60 seconds were easily detected by amplitude integrated EEG. And it is very difficult to track back all the conventional EEG recordings, but it is very easy to interpret and track amplitude integrated EEG as it is very compressed data. And the inter-observer agreement is also very high at 0.67, and with sensitivity and specificity approaching almost 80% when we use two-channel amplitude integrated EEG, and we should correlate with the raw EEG. So that's very important. Whenever we see an epileptic seizure activity on amplitude integrated EEG, always we should keep a cursor on that pattern and see whether there is a conventional EEG correlate with the continuous spike wave activity or not. So in this two-channel amplitude integrated EEG, we can see one cerebral hemisphere is having seizures onset, whereas other cerebral hemisphere is not showing any seizure activity. So that's how this two-channel amplitude integrated EEG will be much more helpful to localize to at least to hemispherical level. Whether we use amplitude integrated EEG for compulsory to start for therapeutic hypothermia or not. So one study done by Sarkar, there is a low negative predictive value for a normal or less severe amplitude integrated EEG in infants diagnosed with encephalopathy. So normal amplitude integrated EEG means lower margin will be above 5 microvolts and upper margin will be above 10 microvolts. So if lower margin is less than 5 microvolts, obviously it becomes a continuous discontinuous record. But sometimes what happens with the ECG leads, there will be an artifact due to this electrocardiogram, as this lower margin can be elevated, thereby giving a false continuous amplitude integrated EEG. So that's how there will be a low negative predictive value for a normal amplitude integrated EEG in infants. So thereby there are chances that we may miss encephalopathic babies. In preterm babies, obviously this background of amplitude integrated EEG will be less less continuous and more or less more discontinuous only. And Budjalov, he quantified actually this amplitude integrated EEG with a scoring system among preterms. He has taken 4 variables like continuity, cyclicity, bandwidth, and lower broader amplitude. And scores from 0 to 13, the overall scoring will be increasing as the gestational age is increasing. And premature infants who are less than 30 weeks of gestational age with intraventricular hemorrhage, they show increased discontinuity and seizures and decreased amount of sleep-wake cycling. Decreased continuity and bus suppression were noted in progressive post-hemorrhagic ventricular dilation. So obviously we know in preterms IVH is a complication, and for which post-hemorrhagic ventricular dilatation is extended complication. If it is a progressing, the amplitude integrated EEG will show this decreased continuity and bus suppression. And those findings will be reversed if you place a ventricular drainage device. And increased burst rate and earlier onset of cycling are associated with better outcomes. In preterm babies, the burst activity, as we have discussed previously, if the spikes are less than 130 per hour, it is associated with poorer outcomes. So medications like phenobarb, midage, morphine, they overall decrease the voltage and cause a suppression pattern, and they increase the interburst interval also. Let us see some artifacts. Like we have discussed already, electrocardiogram, it falsely elevate the baseline of amplitude integrated EEG, thereby converting a discontinuous amplitude integrated EEG into a continuous. Means an encephalopathic baby can be interpreted falsely as a normal baby. Or some patient movements or high frequency oscillator ventilation or electrode placement. We'll see some examples. So here it is an artifact in this amplitude integrated EEG, which is caused due to high frequency oscillation. So here this conventional EEG is showing a muzzle artifact, which is reflected in amplitude integrated EEG as elevations in the lower margins of the amplitude integrated EEG, which can be falsely interpreted as seizures. But when you keep the cursor there and see, obviously you won't see any continuous spike wave activity. And in this example, so in here our residents thought this is some ongoing seizure activity, but when I saw there is a lead displacement, and once we correct it, it went away. So it came to baseline again. So we should be alert about these lead artifacts also. So let us see simple 7 steps how to go ahead with this amplitude integrated EEG. So before starting amplitude integrated EEG for any baby, we should have the background story, what exactly the baby is having, what we are expecting to see, and what we are going to monitor. That it should be very clear for us, and we should evaluate the sensors and signal quality. So this impedance, obviously it should always be less than 30 ohms, and we should confirm the signal being good before interpreting. And then we should classify the amplitude integrated EEG pattern into either continuous or discontinuous or bus suppression, or it is a flat tracing or continuous low voltage, depending on the criteria what we have discussed previously. And sleep wake cycling, we should be observing whether it is regaining a sleep wake cycling or still it's not there. So we start to see sleep wake cycling as early as 28 to 30 weeks of gestational age. And in birth asphyxia babies who are started in hypothermia, if we could see sleep wake cycling in the first 36 to 72 hours, obviously it indicates a better neurodevelopmental outcomes. And always we should observe for the asymmetries. So here in this baby, you can see this low voltage, continuous low voltage activity on the right side. So it indicates some pathology on the right side. And whenever we see this asymmetry, we should be cautious that maybe on that side there might be some scalp edema. So that also will cause this decreased amplitudes. So we should be cautious to look for those local edemas. And then we should identify all suspicious areas, and we should correlate with EEG. And overall, we should describe the stability and long-term trend of the amplitude integrated EEG. So means previously it was discontinuous, and whether it is changing to a continuous record, whether sleep wake cycling was not there initially over a period of time, whether they are appearing or not. Those trends we should be describing at the end of the interpretation. So at last, take home message: amplitude integrated is very easy to interpret and very easy to apply for the babies, and it is more useful in HAE babies prognostication and seizure detection. And we should always be aware of artifacts. I have not touched upon actual placement of bleeds. If anybody wants to know, I can explain. Thank you, sir.
Dasratha, do you have any quiz for them? Just show and
No, sir.
you could have planned something like that.
Yes,
Yes, Somashri, over to you.
Yes. Thank you very much. It was a really excellent presentation, especially the last point, that is a 7-point checklist for
yes.
all of us who are working in the NICU. So I like to deal the questions. So the first question was on impedance. So one of the participants has asked that how does it affect aEEG? Mainly how to handle it. So how to decrease it, or how to interpret whether we are at correct impedance or not. So how to check it basically.
So before applying amplitude, these leads, we should rub with a new prep lotion. So that will have some particles. So that will take away all dirt or dead cells over the skin, thereby making it more easy for the electrode to attach to the scalp, and thereby it decreases the impedance. And if we don't do that procedure, obviously the impedance will increase, the pickup activity will be very less, and it won't be accurate.
So basically they want to ask that how to judge it, whether the impedance is correct or not.
Yeah, this amplitude integrated EEG mission will have indicators, madam. Once it crosses 30 ohms, it will mark red color. So we should be seeing that one. It should always be in green color. So only if it is green means our impedance is in a proper range.
Yeah. Okay. So another question is on, is it mandatory to do conventional EEG? Basically, they wanted to know that what is raw EEG. Every time you were showing in your slides now, the
Yes,
upper one
madam.
is raw EEG and the lower one, the AEG.
Correct, madam.
Basically,
Yeah,
yeah.
in amplitude integrated EEG, they will have inbuilt raw EEG also, madam. So in the lower portion, it will be showing amplitude integrated EEG. In the upper portion, they will be showing the continuous conventional EEG recording also.
Yes.
So obviously lower portion, in one screen, it will show almost 3 to 4 hours of record. 3 to 4 hours of conventional EEG record, it will be showing in one screen. At a go, we can just go through 3 to 4 hours of conventional EEG with the help of amplitude integrated EEG. But whenever we have a doubt that this area might be, child might have got epileptic seizure. So on that area, if you can keep the cursor in the review, so yeah, that cursor point, it will show the conventional EEG recording, how exactly that 10 to 20 seconds of conventional EEG was going on. If it is also showing continuous spike wave activity, then it is confirmed that wherever you are suspecting epileptic seizure, so wherever your baseline and upper margin is elevated, abrupt elevation was there, then only you suspect epileptic seizure. So at that point, we should keep a cursor and we should correlate with the conventional EEG. So obviously, amplitude integrated EEG mission is having inbuilt conventional EEG recordings also, ma'am.
Yes, basically, it helps in to deal with the artifacts. So it is very important to differentiate from the artifacts. So that is the main important thing. So one of the participant has requested you to repeat the 7-point checklist.
Yeah, sure. Yeah. Can I, sir?
Yeah, I know. Sorry to interrupt. We also have the expert, Dr. Vaikundaraju. So I wanted to make a small request to Dr. Vaikundaraju, sir. Please feel free to interrupt in between. Please, we'll have your comments at the end. But then, any time when a point is being discussed, please feel free to. I don't know anything in between. Someshri, please continue.
Yeah, sure. So one participant has requested you to repeat the 7-point checklist. So will you please repeat the 7-point checklist, which is very useful in day-to-day.
Yeah, sure.
Yeah.
So before starting amplitude integrated EEG for any child, we should know the background history, what exactly we are suspecting from that baby. If child is having focal seizures, obviously one cerebral hemisphere we suspect to have some pathology. If it is a generalized, if it is a birth asphyxia, we should know the generalized brain activity, whether it is a discontinuous normal sleep cycling and continuous record over a period of time. So those things we want to monitor. So that thing, what we exactly want from amplitude integrated EEG, we should be very clear before starting amplitude integrated EEG. Plus the sensors and signal quality, we should be sure, as we have recently just now discussed about the impedance. Second point, sorry, 1 second. Then we should classify this amplitude integrated EEG depending on the pattern and voltage criteria. We already discussed this continuous normal continuous record means the upper margin is above 10 microvolts and lower margin is above 5 microvolts. This discontinuous normal voltage means upper margin is above 10 microvolts, but lower margin is below 5 microvolts. So you can see in same EEG, we can see discontinuous voltage and continuous voltage. So that means in discontinuous voltage, it can be record of a sleep, quiet sleep, and continuous bandwidth can be in wakeful state or in an active sleep. But if there is a sinusoidal smooth transition between this broad bandwidth and narrow bandwidth, obviously it is a normal record with sleep wake cycling. But if we don't see any sleep wake cycling, but it is a continuous discontinuous record, means having this upper margin above 10 microvolts and lower margin below 5 microvolts, it is a discontinuous record and it should not be considered as a normal for a term baby. Similarly, this burst suppression, the upper margin will be less than 10 microvolts and lower margin below 5 microvolts, having a continuous burst activity, continuous spike activity. Inactive or flat tracing is both upper and lower margin or below 5 microvolts. Then we should identify sleep wake cycling, as recently we discussed. And the earliest gestational age where we see sleep wake cycling is 28 to 30 weeks of gestational age. And in HIE babies who are on therapeutic hypothermia, if we can see sleep wake cycling to regain within 36 to 72 hours, obviously it indicates a good neurodevelopmental outcome. And always we should be observing for the asymmetry in the amplitude integrated EEG. So in this example, the right side amplitude integrated EEG is showing continuous low voltage pattern, and which is correlating with the pathology on the right cerebral hemisphere. And always whenever we see this asymmetry, we should be cautious whether they on that side is there any scalp edema like cephalometoma, subgaleal hemorrhage, or caput succeedum. So we should be very cautious whenever we see such an asymmetry. So then all suspicious areas we should correlate with the raw EEG. Otherwise, we'll interpret all artifacts as epileptic seizures. So then overall trend of amplitude integrated EEG, we should document how it went in the past 24 hours. So the trend is very important, whether it is going from continuous record to discontinuous record, then obviously something is going wrong. If the trend is from discontinuous record having no sleep wake cycling, it is going towards a continuous record with regain of sleep wake cycling, means the brain is improving. So that trend is important to be recorded and documented.
Yeah. So as a continuation of this, we know that age is basically evolving in nature. So one participant has asked that how long should we monitor this aEEG? So he has not mentioned for context what is the case HIE or something else, but he wants to know that what should be the minimum duration for aEEG.
Minimum duration, at least it takes 20 minutes to have some recording and amplitude integrated EEG. So obviously minimum it should be 3 hours, so that at least one screen length amplitude integrated EEG we can go through. But it depends
maybe,
on
maybe
it depends on the babies.
This question may be how much duration you should record. When is the end point? Maybe that may be the meaning, not the minimum duration.
Okay.
When you will going to stop the amplitude?
For babies with hypoxic ischemic encephalopathy on therapeutic hypothermia, we should start within first 6 to 12 hours of life, and we should continue throughout the hypothermia period, and to continue even after hypothermia stopped for at least 24 hours. So why means those post hypothermia, in that period, rewarming period only, there are increased chance to have seizures. So we should monitor for at least 24 hours after hypothermia. And other reasons, like if there are seizure mimics like tachycardia, hypertension, apneas, to document those things until at least 2 to 3 such events are documented, we should continue amplitude integrated EEG.
Yeah. So in this context, may I ask Dr. Boykanto that for a HI baby who is undergoing cooling, so at what point do you recommend to prognosticate the parents? Is it at 48 hours or beyond that at 7 days of life? So although it is an adjunct to the clinical assessment along with imaging, but if we focus on aEEG per se, so what should be the ideal time to comment on the prognosis?
Yeah, based on aEEG, usually the continuous background should be there after cooling. So if it is continuous background PX at least for 12 to 24 hours, you can tell the long-term prognosis is good. But if it is still discontinuous and still seizure activity is there, then usually it indicates long-term prognosis will not be so good.
Okay. So again, I request Dr. Boykunta, because more than one participant has asked regarding what is exactly that birth separation, why it is named so, or what is it exactly. I think Dr. Dasharatha has again explained in the 7-point checklist, but still they're asking. So I think we should.
Yeah. Birth separation usually you may be knowing that you will see commonly in West syndrome, epileptic spasm. Usually there will be a burst followed by suppression. So in EEG also you will label term burst suppression. So where lower voltage, as you already discussing, the lower voltage is usually less than 5 microvolts, but upper margin also will be less. But in between there will be burst of seizure activity where upper margin crosses more than 10 microvolts. So it is burst followed by suppression. It can be sometimes difficult, especially in the premature babies where discontinuous background is there. So you should always interpret in the context of gestational age and also status of this child. Usually in term babies, this burst suppression usually indicates usually seizure activity. In premature baby, you should always interpret, because in lesser gestational age, sometimes it can be mistaken for trace discontinue as a birth suppression also. So basically, it should be differentiated gestational also, and it gives important clue for birth suppression. Sometimes seizure activity, sometimes it can be seen following seizure management also, when you are monitoring seizure properly, and still it indicates maybe persistent seizure activity also.
Okay, thank you, sir. So, Dr. Dasharatha, one participant has asked an interesting question: how to differentiate benign idiopathic seizure from seizure, actually, from in EEG. So, when to assure that yes, it is benign idiopathic seizure, and when it is not. So, can we interpret from aEEG?
No, madam. In aEEG, it will say just whether it is a seizure or not. Whether it is a benign or it is coming from epileptic encephalopathy baby, we should see the baby clinically and judge.
Yeah, usually in general, usually the benign or malignant, it depends on clinical diagnosis. But in a regular EEG, usually the frequency of seizure, like abnormal burst suppression, usually indicates malignant epilepsy syndrome. Benign usually will not get like burst suppression pattern, all those things, and background usually will be clear. But always you should be in the clinical context, not alone by EEG.
Yes, sir. Okay, so another question is it necessary to do an EEG for breath holding spell? So, one of the differential. So,
No, usually usually diagnosis is clear. Breath holding spells, whether EEG comes abnormal or normal, usually will not treat. So usually the EEG recommendation is not required.
Okay, sir. So I want to ask one question that regarding these artifacts, no? So mainly when we see a baby is on multiple anticonvulsants, especially the baby is almost comatose like that. So obviously the background activity will be definitely altered. So how to interpret in such situation? So from aEEG actually. So the background activity will not reflect the actual one, as the baby is already on multiple anticonvulsant, multiple drugs. So in this situation, how to handle or how to interpret?
So
Or should
usually,
yeah.
So usually in those who are already the medicines are given very high dosage, the background as already you were discussed that there are 5 types of background. Lower margin like flat background are usually there are 2 flat backgrounds, 3 background. One is burst suppression where again less than 5 microvolts, and flat background also where also less than 5 microvolts. But where there is sometimes there will be variation in the background when there is a stimulus is there. But sometimes stimulus also there is no variation, it is very flat background, usually indicates very poor prognosis. But usually when subtle seizure like non-conscious status, sometimes as I told, both lower and upper margin elevation will be there, that is an indication. Otherwise it may be an artifact also, and you should always correlate with the other whether electrodes are attached properly, or any artifacts, also any patting is there, baby's patting, all those things should be considered. So that gives important clue.
Yes. Yes. So one question is there, chat box, that probably in the presentation, Dr. Dashrath has mentioned that if there is less burst in the preterm neonate, that indicates the poor prognosis. So they wanted an explanation for that.
Less
Preterm,
burst.
Maybe in burst activation pattern, if you can see in the preterms, if they are having less burst activity, cortex is not excitatory and not active. So that means some destructive process is going on. So that is a poor indicator. If they are having number of bursts for more than 130 means it's a little better prognosis when compared to less than 130 per hour of burst activity. So it indicates cortical activity, madam.
okay, sir. In the initial slides, you already showed actually how to class the electrode, but still one participant wants to know how to class the electrodes actually in real life.
So normally we'll keep one ground electrode at the forehead and two electrodes at parietal regions. On left side P3 and right side P4. So it gives overall brain activity. If we want to have a bihemispheric pattern, we should add two more electrodes, C3 and C4. C3 will be two fingers anterior to the P3 and C4 will be two fingers anterior to the P4. So like this, two central and two parietal leads we can place so that we can have the bihemispheric pattern as we have seen for some examples.
Okay, sir. And one wanted to know EEG pattern in myoclonic seizure.
Easy pattern, conventional easy will show spike polyspike waves, but amplitude integrated easy, I don't think it will show any different pattern. It will show just the abrupt elevation of lower and upper margins.
Yeah. And I think we should remember the thing that always, apart from HI, whenever we are suspecting a seizure, a subtle seizure in a baby who is otherwise encephalopathic, not HI. So we should remember, I think the EEG is a gold standard because, many cases AEG can miss the subtle seizure, can miss the focal seizure or seizure of very short duration. So I think this should be a there should be a message for the all participants that EEG is a gold standard for neonatal seizure other than HI. So any comments, sir, Dr. Vaikuntha, in this regard?
Always EEG should be always interpreted in the context of regular continuous EEG or video EEG. If at all, if it's possible, it is EEG is a complement to regular EEG. So the management epilepsy syndrome usually should be managed EEG requests followed by regular EEG should be done to confirm the exact epilepsy syndrome and also the severity and management. That is important.
And many times we used to get calls from NICU when I was in fellowship in periodic neurology. So baby might have seizures or seizure mimics, then they will order EEG and then they get the baby into an EEG lab and get it done. But obviously we are in a helpless condition to say whether that activity, whatever they observed, to say that as it is a seizure or not. So we need a continuous EEG monitoring and to record those events, and then we can able to say whether that is a seizure or not. So interictal EEG is helpless. We can just comment on the background, how exactly the background is, that's all. But we can't comment whether that event what they have observed is exactly seizure or not. Very difficult to see.
So ideally, gold standard is video EEG, but that cannot be possible in all the setup because of manpower and also it is not very it is time consuming and also lot of manpower. It cannot be possible in all the places where regular video EEG is possible. But definitely aEEG is useful, and whenever there is a suspicion, it should be confirmed with regular EEG so that it gives you more important values.
So one last question. There is, how to differentiate drug-depressed baby from seizure encephalopathy on aEEG. So whether the baby is depressed due to drug or there is some pathology is there for the seizure encephalopathy. So is it Can it be differentiated from aEEG?
No, madam. I think it's difficult to differentiate. Obviously, once a baby is seizure free, or either it is on electrographic or clinical seizures, so we will be weaning of anti-epileptic drugs. So with weaning of anti-epileptic drugs, we'll see the trend of aEEG going from low voltage to discontinuous, then to continuous regard. So that trend obviously will say that baby is improving and the brain is good. But if it is not improving, means obviously that is not due to drugs and there is a real pathology in the brain itself. So that's how we can comment.
And regarding one more question, that in the initial slides you showed that electrode placement, so P3 P4, so that is bitemporal and also the biparietal. So another line you added that there is multi-channel EEG, so that increases sensitivity. So I think this message should be clear for the participants that regarding single channel, multi-channel, single electrode, multiple electrode aEEG.
Yes, madam. So what is single channel or what is two channel? So we normally use, normally many people will use one channel. One channel means using P3 and P4 and measuring the voltage difference between the P3 and P4. So P3 on the left hemisphere, P4 on the right hemisphere. So difference between the two voltages in the electrodes will see the general brain activity. We can't differentiate whether it is from the right or we can't differentiate whether it is from the left. That is single channel aEEG. If it is a two channel aEEG, we'll have two more electrodes, that is C3 and C4. So C3 in the central region on the left side and C4 on the right side. So then we'll measure the difference of potentials between C3 and P3 on the left side and potential differences between C4 and P4 on the right side. So we will have the clarity whether the abnormality is from the right hemisphere or it is a left hemisphere. So that's how this two channel aEEG will be more helpful to differentiate which hemisphere is abnormal.
Yes. So one the technical question is there in critical cap. They have experienced probably that it interferes electrode placement. So what can be done? Critical cap, if they use for cooling the babies with HIE, so it actually interferes regarding the electrode placement. So what can be done?
I don't have experience with critical.
See, actually, can I answer this, Somasri?
Yes, sir. Please.
See, critical cap was very, I mean, the Olympian, this concept was, I mean, this was in the initial days when we were thinking about head cooling as a means. Now we have moved away to total body.
Whole body cooling.
And now in critical cap, they actually, there were people who tried to do CFM monitoring in these babies. And then they realized, if you look at some of the results from the NICHD group as well as from the TOBI group, the earlier ones, I'm talking about the early reports, probably, not much of useful they found. So probably, first of all, we don't do it. And secondly, when you, it is basically if you cannot have proper conduction happening because of whatever reason, then probably you will not get the required readings. So probably it will be a challenge to use CFM on a baby on critical cap.
Yes, sir. Sure. So I think there is no more question in the QA section and neither in chat box. So
one question somebody had asked, that's a totally different administrative question. Can the next week's session be planned on Tuesday? I think that's a valid point.
yes.
14 to 16 is exam, and if you're planning on 13th also, one day early also, they will be traveling. So let me see. And that I will have to just arrange any suggestions on topics you want, please do let me know. Otherwise, we'll try to get some exam-oriented topic. Most probably, it will be a guest lecture because asking somebody to present a case on short notice, I'm not sure. If somebody is willing, please do let me know. Otherwise, we will not necessarily from neurology, from other systems we are not covered also we can have. So some exam oriented topic I will try to arrange on Tuesday. You will come to know in a day or two regarding this. And regarding this today's session, now we have some recent insights on this on use of aEEG even in preterm babies. So this was covered in one of the Learn from the Legend session. I posted the link in the chat box for those of you who are interested. You can go back and watch that session as well. So, anything else? Before we conclude, I would request Dr. Vaikundaraju to, give some parting messages also.
Yes, sir. So aEEG is very important. Basically, it will be monitored for one is encephalopathy, other is for seizure detection, and third one is important is prognostication. So you should have some aims before doing aEEG. Maybe we are already knowing, and for to detecting seizure or a seizure-like activity, because it is 50% sensitivity and specificity in detect clinically, and also it can be mistaken even by expert also. So that is very useful, and it should be confirmed by regular EEG. And it also gives very important point for prognosticating the child with encephalopathy.
So, anything more, Somashri, Dr. Dasratha?
No, sir.
I think everything has been covered already.
So, hope today's session was useful for your clinical practice as well as at least those of you who are using CFM or who are familiar with CFM, and for others, at least for exam purpose, it should be useful. Continue to aim to get it if you do not have, because it actually makes life easier, especially when you are cooling babies. Uh, Now, with this, I think we will close today's session. Please give your feedbacks regarding the session that you would want. We are nearing the end of the year, so now the modules that are covered will be on a on-demand basis. And those of senders who have not presented the cases and interested to present, please do let me know. Next week, as we said, we will not have class on the regular day, that is Friday. We will be having it most likely. I will confirm in a day or two on Tuesday, as suggested by someone, and then thereafter we will continue the same pattern. So, I would really like to thank all the three experts today. Dr. Dasarada for preparing and presenting aEEG, simplifying the whole concept and then making it look very easy for people like me to read EEG without any sort of doubt, And then but I tell you, when you start using it, it's not as simple as what he told. But then this is the basis you need to use. If you have a CFM, you will realize that so many times you still are left in doldrums actually. But that's the way. Learning is learning. There is always a learning curve in this. So thank you, Dasratha. And I also like to thank Dr. Somashri for moderating this session so well. She has actually added whatever was not covered, and then done. Thank you, Somashri, for sparing your time for us. And also, special thanks to the expert for the session, Dr. Vaikundaraju. Sir, thank you so much. It is so nice of you to join us, neonatal community, and spending your time with us. We look forward to more interactions from you in the future as well.
Thank you.
So much.
Thank you.
Friends, and finally, thank you all for joining today. Let us continue to go on this journey of learning. So, NNF Noel is there to continue in the years also. So, please contribute. Any inputs to improve the mode, how we present this series, and other design, everything is most welcome. I think with this, we'll close today's session. Thank you so much. Good night, everyone. So, hope all of you had a nice Dasara. So, now let's avoid Diwali. Bye.
Bye, sir. Bye, madam. Thank you.
Bye bye. Good night.
Good
Good
night.
night. Good night.
Mateen, you are there?
Yes, sir. Just ending up.
The link now I posted to you also, because in continuation with today's class there is a YouTube video I posted to you. Please post in the group so that they can read that.
Okay, sir.
Next session we will have most likely on Tuesday, as suggested by somebody,
Okay,
because
sir.
I will let you know in a day.
Done, sir. Thank you, sir. Good night.
Good night.